Priority nursing diagnoses are here, and again, hopefully if you look at the list, they are very obvious and things that are important. You know, typically with a diabetic patient, especially one that is not managing their disease well, that ineffective health maintenance is a really good one, but it certainly could be effective health maintenance if they're doing a great job with their diabetes. Again, you see at the bottom the risk for complications of the metabolic acidosis and risk for complications of hypokalemia, especially again with that DKA or HHNS. A lot of knowledge deficit and teaching goes into educating our diabetic clients as well. Survival skills for diabetes education. This would be a sample that is often contained in the diabetes education packets that we give to our patients, sort of a checklist. And so again, it's things that we've already talked about, but I would like you to look closely at this checklist. And this is a good way for you to assess your learning as a student and say, gosh, do I know what all of that is talking about? Do I know the medications well enough to teach them? Do I know the signs of hypo versus hyperglycemia? Sick day rules, when to call the doctor, foot care. Again, we've already talked through these things, but this is a good chance for you to really quiz yourself and say, hey, do I know? Do I just know them superficially, or do I know them deep enough to be able to really regurgitate that information and teach my patient about it? So with the diabetic teaching plan, we always start with assessing for any teaching plan that we're going to develop for a patient. What are their concerns, asking open-ended questions, assess their readiness to learn, their baseline knowledge. Do they have any barriers to learning? What is their preferred method for learning? Do they want anybody in particular included in their learning? Again, for elderly considerations, I would definitely keep in mind the vision and hearing part of it, obviously the memory part of it. Safety is huge with that elderly population, even financial means to afford their medications, their insulins, the healthy food that they need. What are the modifications for them for exercise programming that would be appropriate? Do they need somebody to come in for medication setup? Those are all very good things that hopefully you're thinking about with that elderly population. With the pediatric population, I think the biggest things here, while there are lots of things we could talk about, is just to make sure that we're not talking down to them, that we're actually talking to them and not just their parents. It's, you know, we need to make sure we're involving everybody in the teaching because we don't want to leave the parents out either. But, you know, especially if they're adolescents and they're getting older, you know, we need to make sure that they ultimately understand their disease and management and that they can feel independent in doing that. Of course, the younger they are, we're going to do a lot more play with our teaching and toys and games and practicing with dolls and demonstrations and things like that. You can see that there is there is Joint Commission rules as far as what we do have to teach. We also have a lot of hours of education that are covered under most insurances and Medicare, and you can see that they get 2 hours continually every year outside of that initial big clump of education that they qualify for. So again, we want to make sure that they're aware of that because there's a lot of people that are underutilizing the actual hours that they can get. Again, diabetes educators, I know at Essentia, they changed the name recently here in 2019 to Diabetes Care and Management Specialists. So again, Diabetes Care and Management Specialists or Diabetes Educators, and these are advanced practice RNs typically in this role. I found this picture and I thought it was really good showing the elderly considerations. So again, for those visual learners, hopefully you can just kind of take a peek around the circles here and see some of the things that we've already talked about that we should consider for that older age group with diabetes. The standards of care here are listed, and these are from the American Diabetes Association. So you can see what they would recommend patients doing every 3 months and every year as far as their checkups and monitoring their A1C, blood pressures, foot exams, etc. We've talked quite a bit about the special considerations for the child versus the adolescent. Again, a big thing there is this acceptance. It's really, they want to be accepted, they want to fit in, they want to do what their friends do. You know, it can be very difficult when you think about going out to pizza or all the different things, you know, drinking pop or sugary type drinks. Of course, alcohol drinking, once it gets into that, you know, over 21 and college age years, can be challenging. So lots of things that we definitely want to talk about with that age group and hopefully help them feel good about it and accepting of it, because it's not as if they want a diagnosis of diabetes, but it's not something that they can change. And so we really want to help with that acceptance piece. Again, we've talked about some of the elderly considerations already. As far as the diabetic patient undergoing surgery, they typically will be the first on the surgery schedule because they do have a risk of their NPO, and so we don't want them to go hypoglycemic. Typically, this isn't really a problem because, of course, during surgery, they have the stress response that increases their blood sugar. So it seems like that surgery stress response and them being NPO kind of equalize each other out. But we definitely want to check those blood sugars right before surgery, right the first thing into the recovery room. Once they transfer out to the floor, we'll get their blood sugar right away as well. And then we'll kind of get on more of a regular schedule of checking their blood sugar, but we do check it more frequently initially post-op. As far as the hospitalized diabetic client, the main thing here is, you know, if they're taking steroids, remember that's going to significantly increase their blood sugar. If they're on a TPN, total parenteral nutrition, that contain up to 70% dextrose. So that certainly is going to increase their blood sugar and the need for correction sliding scale for both steroids and TPN. And then they're also just having less exercise, they're eating different. So all of those things can alter how they're being managed as well. Not to mention that they're sick, they have an infection, they have pneumonia, they have other things going on that are increasing their release of cortisol. Alteration in diet, again, if they're NPO, different eating times, different eating types of food. If they're on a clear liquid, they're higher in simple sugars. So again, TPN, if that's their diet. So that's where I was going at with the alteration in diet bullet point. Again, always assess, educate, review. It's really fun to help our patients learn. And so hopefully you can take time to do that with each and every one of your patients. The answer here is 1. The answer here is 2. Answer for this one is 2. Answer here is 3. The answer here is 1. On all of these sorts of questions, the main thing is to know that you know that all 3 of them are the signs or symptoms of hypoglycemia, because in some of the other answers, 2, 3, and 4, there might be one of the 3 that is hypoglycemia, but the other 2 are hyperglycemia. So you do have to know them well enough to be able to differentiate out or select all that apply. So you do want to spend some time learning them for sure. The answer here is 2. Answer here is 2. Answer here is 3, glycosylated hemoglobin or A1C. And the answer here is 3. That level of consciousness responds quickly to changes in pH and restoration of fluid and electrolyte balance. And then that urine output decreases as hyperglycemia is resolving because there's less osmotic force. So again, 3 with that combination improved LOC and decreased urine output would really be a good sign that we are making some headway.